Welcome everybody. This is actually our 29th digital dispatches, and it's one of the mini series that we're doing that's focusing on talking to clinicians, staff, those in roles that have worked or are currently working in a hospital that have implemented the EPIC electronic care record system. So I'm not going to say too much more, but we're delighted that Eleanor Conway has been able to join us today. Eleanor works in Great Ormond Hospital. We had one of the mini-series previously where we were talking to some of the guys that were involved in it there, and we asked staff across HSE here in Northern Ireland, were there any specific roles that they wanted to hear from, and speech and language therapy or that type of setting and environment was one that we had some staff come back to us and say that they would be really interested in hearing from people's experiences that had moved across to the EPIC system. GOSH implemented the EPIC system in 2019 and Eleanor was involved in that. So I'm going to let her introduce herself and give you a little bit of a rundown on what she does and her experience of the EPIC system. I'll hand over to you, Eleanor.
Thank you, everyone. I'm just going to try and share my screen. To reassure you all, I'm not particularly technical, but I have found the EPIC system to be not horrendous. I think that's probably the best way to put it. So I will just share this if someone can give me a little nod to say that this comes up in the way that it should do. So yes, I'm Eleanor Conway. I joined Great Ormond Hospital in 2009, so I did 10 years pre-EPIC and now work with the EPIC system. I will call it EPIC. I think your system's called Encompass, something slightly different, but I will call it EPIC, otherwise I'll just confuse myself. I work in the acute trust in both inpatients and outpatients. I also do a little bit of imaging and X-ray and other bits and pieces across the system. So we've needed to integrate across a number of different systems within it in order to work functionally well. So I will just kick off. Please put questions in the chat. Very happy to answer questions. I also previously have worked in community and used systems like Rio and things like that in the past, although that is a long time ago. So I can have a think about some of that if needed. So before we had EPIC in the inpatient service, we would receive a phone call or a bleep asking us to go and see a patient. We would be given a patient number and a patient name. We would be able to look up where they were on what ward, and we would need to look on any available letters on their what was called our clinical document database. If they were a new baby, they might not have anything on that. If they were a frequent flyer, they might have some letters that have been sent in from their community services and some letters that have been sent out from GOSH. And that was predominantly storage of letters. And then we had a different system that had sort of where the patient was in the hospital, sort of where they were sitting, which was called PIMS. So we would then have to try and call the ward to try and schedule in. Wards would be busy. We wouldn't always get through. So we might have to go up, find the patient, find they'd been sent somewhere else. And we would have this sort of constant trail of trying to chase patients. Once on the ward and on the correct ward for the correct patient, we would then go searching for their paper notes, which was usually a book of notes. We might find them missing. We might not be able to find the notes if they've been off on a ward round or were sitting on a doctor's desk somewhere. And they were often incomplete. And if the patient was quite new, not really started or not very well filled in, we would see the patient and we'd need to rely on the relevant history from the family. And then we'd have to do pen, paper notes, black ink, blue paper, lined paper, which we'd often have to start ourselves rather than writing in the notes of the patient because we wouldn't be able to find them. We'd then hand that piece of paper to the nurse and hope that they filed it in the file when it got found. And we would either take a photocopy for it to be scanned in for us to get a record of it, or we'd have to remember what we'd done, go downstairs, always downstairs because we're on the ground floor, to our office and retype that set of notes again into a kind of locally held SLT Word document that sort of held the kind of story of that patient's SLT journey over the course of their admission. And then if we needed to write a letter, we used to dictate this. It used to go to India, come back, need editing, and then would be turned into a PDF and uploaded onto the clinical document database. And any assessments, so I don't know if you're a speech therapist, if you're using any of the sort of paper assessments like the KELF or something, we'd fill that in, and that would all need to be cut up because they're books and then separately scanned in and then uploaded onto that document database as well. So the system was chronic for duplication. Outpatients was even more confusing. So there were two systems. We had the clinical document database, but then also the PIM system, which was how we booked. Patients were booked on the electronic system by our administrators, so they would take names off a separate spreadsheet or waiting list and then put them onto the PIM system for their appointment. And this system also ordered the notes. So we would have hundreds of members of staff all over the hospital walking around with trolleys of notes, delivering them to different clinical areas for different clinics. And frequently, say, surgeries couldn't be booked if the notes hadn't arrived, or surgeries couldn't happen, so families might be sent home if the notes weren't available, or I might see a patient without the notes because I might not worry too much that I haven't got the notes, but I'd be reliant on the parents to tell me, to fill me in everything that had happened with that patient. Or if the notes did come, and they were, some of our children, there would be sort of 3 books of notes. It wouldn't be possible to really read the relevant stuff. Lots of it was duplication. Again, we would handwrite the notes, black pen, blue paper, and we would put this into their file, and then we would again separately write a note on our sort of system for how we sort of did that. And we would separately upload assessments. We would dictate the letter, and then that would go onto the clinical document database. And that was our pre-EPIC system. It was some of the problems. Lots of the notes were incomplete or lost. You might find like a lone bit of blue paper with something important written on it on a ward somewhere and not know which patient it was for. And we had different systems for booking in appointments, scanning documents, notes, transport, interpreters, imaging, labs were all completely different systems. And I didn't have access to lots of those. So if I wanted to book imaging, if I wanted to book a video videophroscopy for a patient, I would need to print off a special bit of sticker with our printer that only works certain days and print it off in those margins, and then I would need to take that round to X-ray and physically book it in, and they would book it in onto their system. The usual problems that I think with paper notes, illegible handwriting, I'll hold my hands up, I'm a culprit of that one. Very unclear with what plans, whose plan was what, or who'd seen who, and lots of systems that didn't communicate, and a really high reliance on parental reporting. So that was sort of the main issue. I know that our hospital talked about a couple of different systems, and we were pre-warned a long time in advance that we were moving over to a different system. And before go live, for at least a year and a half before, there were lots of kind of random requests for letter templates or assessment pro formas or things that we might need on the system. So they were trying to build in systems that we were already using. And there were lots of meetings regarding what we needed, so what standardized things we might want to use, and evaluation of what we might need in terms of rights or responsibilities. So if you order imaging, you need certain rights. If you order labs, you need certain rights, that kind of thing. And we were super lucky because not only was one of our managers from a hospital that had previously used EPIC, a member of the SLT joined the build team. And I have to be quite sad, she never came back actually, but she did manage to build us something that at least used some of the same language and things that we were used to using. So we were really lucky that we had someone on the ground who was able to build our system in a way that we understood and that we'd had good engagement in. Now, I will just say that's feeding. I work in feeding. The build for what some of my communication colleagues do maybe wasn't quite as good because that wasn't her expertise, but certainly it was better than some of what was built for other teams that hadn't had a member of staff on the build team. There were lots of requests for staff engagement. Come and try it, come and see it, come and have a play around, you know, try and see if this works. What else do you need? What would be critical to your working over the first 10 days of EPIC? What do we desperately need to build in initially? And then on go live week, I completed training with about a month to go. We were trained in inpatients and outpatients, irrespective of our role, whether we were inpatients or outpatients. And we were trained with all the other AHP teams, so physios, occupational therapists, rather than just speech therapy, which wasn't a massive problem because the build that was originally there was quite generic. So that wasn't a huge issue, but there was obviously really high engagement in training. And then on the day of go live, we were really lucky. I think because we're gosh, someone from Canada had said, oh yeah, I'll go and shadow the speech therapy team for 2 weeks. And she came over for a week, and she'd already done a go live where she worked in Canada, and she was kind of on the ground. She moved around clinics, sat down with someone next to you and helped you set your screen up and help you identify which bits of the screen you needed and which bits weren't going to do anything for you. And I know there were quite a lot of unforeseen problems in the first few months. So I know we personally had a problem with our administrators not physically being able to put referrals onto the system. There was some sort of glitch that meant that they couldn't get it to register properly. And I know that there were issues with ordering of medications. That was something where I think pharmacy hadn't had somebody on the bill team and potentially should have done. And the other really challenging thing that we hadn't foreseen was everyone's screen looks different. So you can't really help them navigate because their drop downs, their boxes, everything is really different. So I try and get an appointment booked for a patient. My administrator would say, I can't do this. I'd go and look at her screen and it wouldn't make any sense to me. So I couldn't help her do it. And so our administrators have different screens, our nurses have different screens, our doctors have different screens. And that's good because they need to do different things, but it means if they're saying, oh, I'm looking for how to order a referral to speech therapy, I can't help them do it. I can't physically say click here, there you go, because the way that I do it on my screen would be different to the way that they do it on their screen. And there was at least a year of kind of mild chaos, I would say, with lots of things that we hadn't worked out. So when they took all the patients off the original booking system and put them onto Epic, there were thousands of patients that we'd already discharged. I mean, some of them were in their 50s. You know, we're a paediatric hospital, and our poor administrators had to go down through and delete them all off the system one by one because they were not needed, their notes weren't needed and nothing. But it's just because of the date when they pulled it all off the system, it didn't recognise who'd been discharged, for example. So that was, you know, there were lots of extra admin jobs that we hadn't really foreseen that really were needed to just make the system clean enough to use. So I think, and actually training and support for our administrators, to me, seemed a little bit low, whereas for the clinicians, it seemed to be quite high. But there have been and continue to be a number of glitches that I just think are part of a really big generic system trying to be used by so many different people for so many different things. So what were the problems? So lots of things have safety things that the hospitals requested, and they create something called a hard stop, which means, I don't know if you've ever tried to buy something online and it keeps telling you haven't put your demographic in, or you haven't put your date of birth in, or, you know, and it keeps coming up with a little red line that says you can't move on from this screen because you haven't done this, and that's a hard stop. And so essentially that meant that something like requesting an appointment, if I couldn't get through that screen, I just couldn't get it booked. I just couldn't get it done. And so I would have to call the hotline and they would have to log into my screen and do it for me, which I found really useful because they did it for me so many times, but also meant that there were certain things that took a lot longer because there was this stop that I couldn't get around. And lots of things that had been deferred to admin assistants and clerical staff suddenly needed to be done by doctors and nurses and me, speech therapy. So requesting another appointment, you'd think if you just put their name on a waiting list, someone else will go and book it for you and it'll all get done. The actual doctor has to do that now. So actually, a lot of things that had been sort of deferred as kind of menial clerical tasks that could be deferred to somebody else now has to be done by the clinician. I do feel there was low support for admin teams. I don't, that might just be our perception here. And I know there were difficulties with ordering medicines and imaging in the first few months that needed sort of urgent updates. And I think the large sort of difference is it's a really different vocabulary. So referrals are orders, and medicines are orders, and prescriptions are orders, and then referrals are called something else. And there's things like you might get a hard stop, a problem where it'll say the location isn't right, and I don't even know what that means. I still don't know what that means, but I have to go and edit the location in some way. And I think that causes a lot of initial confusion and a lot of fear of the system because it's completely alien. There were lots of data incidents. Lots of letters that got sent out accidentally, not written properly, notes not completed. We call open files that meant someone else couldn't do something with the file, and lots of data problems like secure addresses not being secure, not flagging properly, and things like that. So some safeguarding-y bits. Again, I don't think you can fix the system completely, but they have subsequently been fixed. So anything that caused massive data breaches was dealt with. And I found this quite fun, but a lot of names were wrong. So our administrator was called Michelle, but when she started at the trust 25 years ago, her name was Halcyon. So everything that came from her had that name on it, which meant I didn't recognise that as our administrator. That's not what I call her. We've got a very senior surgeon who I call Joe, whose name came up as Ignatius. You know, I think that's probably something he's been trying to hide for a long time. But anyway, now we all know his proper name. But it did mean you weren't always clear with who you were communicating with, unless you understood what their name, you know, it might be their old married name, or, you know, their old sort of maiden name or something. So, and I think again that was something I hadn't anticipated, but I found quite funny. But I don't mind about my name, but other people might find that problematic. What are the benefits? I don't write lots of notes anymore. I don't run around looking for files ever. I don't lose files. I don't write bits of paper that I then have to write again and upload somewhere else, which is massive. And all the historical scanning. So we had a team of scanners just scanning in documents for years in preparation for this, means that the files are complete. They might be hard to read. Some of the scanning might be upside down, but the files are complete. Everything you need is there if you look hard enough. And it's worked really well for inpatient systems. It's designed for inpatient systems. So I think if you work in a hospital, you work in an inpatient way, it's really, really set up very well for that. Outpatients has had more difficulties because it's more complicated, but again, it's not horrendous. There's much less risk of data loss. Everything is there. And I think there's a lot more accountability because you can see who opened the file and did what. And you have a data trail. So if someone promised something to a family, it's there somewhere. So when they complain or have issues, and actually for our PALS team, they're really much clearer on whose responsibility it might have been to do something that wasn't done, or what waiting list they need to be chasing. And I think that's much, much clearer. Whereas previously that would all have had to have been done by email, and that's much better now. And then years on, so the system we went live with is nowhere near the system that we use now. It's really adaptable. We've built things in. And like I say, as things have caused problems, they've been fixed, modified, sorted out. We are spreadsheet free. So there's no caseload sitting anywhere else. There's much less repetition. And systems like transport interpreters, imaging, prescribing, referrals, labs, and all the documents are all on one system, which is really good. And I really like that we can message patients directly. So we have my chart open. I don't know if you're going to get that. And we can also message clinicians directly using a kind of chat system, which is much more efficient. Our bleeps all broke and there was nothing to replace them. The hospital wouldn't buy more mobiles. So this chat system has really replaced that system really nicely. I do a lot of research and audit. It's much easier to be able to find everything for patients, to track what's happened to them, to historically look at case groups. So some of our rare caseloads, there might only be a few children and their documents are extensive, and being able to look for that in a much more clearer way is helpful. And it tracks things like time spent with the patient, waiting times, appointment letter time. So whatever your team has set as your KPI target, it will track that for you. That data can be pulled off for you. You haven't got to go back and go and ask for it. The in-house communication systems replaced our bleeps, which I said, which is really good. And actually, Epic saved our bacon in COVID. We suddenly had to work from home, and you can remote in and do everything from home. It's really, really, really easy. And we have Zoom embedded into our virtual appointment system. So when we book a virtual appointment, it's all on the system really nicely. Some of the issues, it still really struggles with really complicated multidisciplinary outpatient appointments. It just can't work out who the lead clinician is or who's supposed to be doing what. It's very difficult. And there is still some difficulties with letters and auto setup, where it might automatically send a really badly worded letter that you didn't mean to send. And there's still some things the system can't do, but obviously that's some of our responsibility to get it built. So I need to go and talk to Epic and book them some time and actually get systems built that would work for us, which we're still doing. And we will continue to do as services grow and change. Keela, yeah, I sort of wanted to if I was going to pour my brain out into yours, what would be good. So you get out what you put in. We were lucky we had a speech therapist who went into the build team. We have had named people who have helped us optimize and build since. I do remember that panic on go live day, that there was going to be this thing that would be a problem. Every patient got their medicine. Everyone eventually worked out how to use the system. It was all right. It was okay. And I think we had a kind of central phone line that you rang when you couldn't get it to work, and then they would virtual into your computer and show you how to fix it. And I used that hourly almost in the first few months. And I think the other thing that I would say is try not to help others. So this sounds a bit bizarre, but their screens look different and you can get it really wrong. But also, if they don't call the line as well, they don't realise there's a bigger problem. So only when we'd made loads of calls and our administrator did loads of calls did they work out that there was a problem booking appointments and come into our office and look at the system and find there was a problem and fix it so that that system could work properly. So, but if we hadn't have made 20 calls, they wouldn't have known there was a big problem. They would have just thought it was one little person with one little problem rather than the system not working for them. So actually, the more calls you make from one team, the more likely they are to help that team, because they just will want to clear that call backlog. I found that actually trying to help people overcome a problem or get around it caused bigger problems than just trying to get the system to work by calling the people who know the system best. That's my sort of best bit. I'm done. Any questions? Look at that, half an hour, did it? Nailed it. I'm going to stop sharing. I know how to do that so that I can see you all again. There we go. Is there any chat? What do I do with paper? Okay, let's start. So yes, paper assessments. That's a good question. We were scanning them in. But also you can build, it's called something called a flow sheet. I know our physio team use it lots, and I know our speech assessment team use it a lot. So you build the system to monitor, to do the assessment. So for example, in speech therapy, it might have the kind of the standardized scores of certain assessments, and you can build the system to monitor that. And then what's really nice is, let's say you do a KELF a year, and then a year later you do another KELF, it will appear in the same column of the flow sheet, so you can see any improvement in score, any change in score over time. So if you use standardized assessments, and I don't know if we ever resolved the issue of so I think we still have to use the paper assessment, because that's the rights and responsibilities of the kind of team that built the original assessment. But what we do is transcribe the scores as you would have done into a report, into these sort of flow sheets. So it'll say something like GRABAS score for voice, or videophroscopy score for something, and then you might then have it, and then you might see that a year ago you did the same and the score is different. So they're called flow sheets, and they're a sort of separate part. And then if you're very clever, which obviously we have a speech therapist on our build team, if you're very clever, you can get the letter to pull the flow sheet out and quote directly into your letter, so that you haven't got to go and find the scores again. But we haven't got around the issue of having to cut up and scan in the individual sheets. That still happens for standardized assessments, but if you quote the scores correctly in the flow sheets, and over time it builds the picture of flow sheets. And that's what I mean by audit. So I can go back and look at that patient group, find their flow sheets and their scores for particular assessments, and tell you if they are or not improving or deteriorating, or whatever is the expectation for their condition. So it does eliminate workload if you build it in, but it's definitely something that for us was built in, and we did not use it for the first couple of years, and then we've since built it to work for us.
Eleanor, you and I were chatting before we admitted everyone. So a quick question, just in the way you used to work and the way you work now. What would you say about that?
I have to say Epic has exceeded all expectations in terms of what is possible. So having worked with several different systems, none of them quite did what was needed in a way that was helpful. And Epic has been able to be built in a way that is helpful. It is still frustrating, it's still glitchy, it's like any electronic system. And obviously the other thing that's frustrating, which I think is NHS wide, is there's certain things I have to do that don't interest me, I don't care whether the patient was or wasn't seen on time, but the hospital does. So I have to add that data in, which, you know, I don't care how long I took, but I have to add that data in because someone's monitoring to get their money's worth out of me and all of that. So, but I think before was fine. We'd problem solved a way of doing it and getting not losing data and getting it to the best that we could, but it was labour intensive. And what's really nice now is if we get an order, a referral for a patient, there's so much information on that patient already there. You can really see if you're needed or not, or if it's already been done before. So we were getting some duplicate referrals and that kind of thing. If you've already said no twice to 3 other people, and then you're having a 4th person asking again for your service that you've already said no to, and that whole history and trail is there. And for other things like safeguarding, actually you can see the family that are calling 20 people. You can see that because it's all there documented, and you can see that you're going to need to be more careful with that particular sort of patient group, or and I think that sort of stuff just would not have come across in paper notes in a way that this does, and it saves everything. So there's a messaging system. You can message the families. My colleague didn't know that went on their file and been like, oh yeah, lovely holiday, thanks, had forgotten that you kind of, and so then like she said, it doesn't do that, but it, there's lots of bits and pieces to it that replaces what we're already doing and records it in a way that means I don't have to think about recording it again.
We have a couple of questions, Eleanor, coming in the chat. I'm not sure if GOSH interact with primary care, or you in your role, if you do anything connected with primary care.
So what I will say is we are GOSH, but UCLH and Addenbrooke's also have Epic, and we can't edit, but we can see what goes on when a patient is in those settings as well. So I would imagine a connection with primary care would look a lot like that. So I can't edit or change an admission or any of the documentation that's happened at UCLH, but I can see what documentation is there for that patient while they were at, as part of their UCLH stay. For us, it's called Care Everywhere. So you click on a certain tab and you'll be able to access all of that information. I would imagine if you're going with community and acute trust all together on Epic, that you would have a system similar where there would be a tab that you could see what was going on in primary care for that patient. The only thing I don't think it would communicate with is GPs. We still have to, that's still done via NHS emails or I mean we don't fax anymore, but phone calls and stuff like that. So yeah.
Okay. Apart from messaging, what else can your patient do via the patient portal?
So they can message us and we can message them. We can also send them documents, so they get all their appointments and documents come on the patient portal, and we can attach PDFs of advice, or so if you've given sort of standard advice and you might have a leaflet that says that, you can send that to them as a PDF. We've also been able to ask them to complete surveys, so we've sent them Survey Monkeys or other survey stuff that comes through the patient portal. The only issue with the patient portal is you have to set it up. So at the moment, if you message your speech therapist via your My Gosh portal, it will come to our generic admin and they have to disseminate it on. And part of that was in case the person had left the trust, or if they were off or whatever, but it means our admin have had to learn to use another system. And sometimes when patients are messaging, it's not always clear if they're pre-referred, if they're at referral point, which team they're intended to go through. So sometimes it's a slightly slower system. I can't think. So yes, they can see their appointments. They can't cancel. They can't cancel their appointment. They definitely have to call to do that, and they can see any of their letters, and they can message me or whoever else questions. That's pretty much it. And I've got to confess, a colleague has a child at the hospital, and she opened it to see what it was like, and she said it's not that user friendly.
Okay.
So it's not very easy to find the documents.
I know my chart for us here, it will be My Care, and I know certainly it's going to be, when it goes live initially, it's going to be quite basic with sort of limited use, other than maybe appointments, until it's rolled out right across Northern Ireland, and then the actual optimization and facilities that My Care can offer will be looked at further and opened up much more.
We had relatively poor sign up until COVID, when all the virtual appointments had to be done through the portal. So then all of a sudden everyone signed up because it was the only way that they were going to get their appointments. So I think we probably would have had lower sign up had COVID not happened.
Okay. Did you have super users in your teams? I know.
Yeah. They had to go on one more half-day training, I believe. And they had these lovely pink tabards that they had to wear for the week. And I've got to, I think I wasn't a super user, but ended up quite interested in the system, so have become the sort of person who likes to play around with it and likes to get things working better. I think our super user, they were just sort of nominally named, but it was, okay. I think we tried to create super users that did inpatients and outpatients like I do, and at the time I only did inpatients, so I didn't do it. But actually, the help desk was much more useful.
Okay.
In terms of that.
Okay. I know you were involved in the implementation and then subsequently and right up, I suppose, until now, all the optimization. Is it easy to identify areas for improvement or where support is most needed from the system? Can you identify areas of good practice easily?
Yes. It was very easy to identify areas for urgent improvement because things just couldn't happen, and people just, and the desperate calls got more and more desperate, and there was a system where you made an online sort of hornbill thing. Some of the other optimization has had to be staged or phased. So I might want a system built. It might not be a priority for the trust to build that system there and then, but also what I'm asking for. So one of the things I've asked for at the moment, you can't, there's a little tiny word on a patient's letter that tells you if it has been sent or not, so sent or open. If it's open, it's still editing and it's not been sent to the family, but it's a very small thing, and actually people can print off and send the open copy, the draft, what is essentially a draft copy, and send it anywhere. So we've asked for draft watermarks to be put on that, on a pre-finalized letter, and that has come back several times with a flat no. Not because nobody doesn't want to do it, but because actually to build it in would be an absolute headache, and so they've decided it's not important. Now, until there's loads of data incidents and data breaches where we notice that's been happening loads and loads, I don't think it will be a priority. But for me personally, I'd really like that. For lots of other teams, they'd really like that. But the hospital, the build would just be too difficult, and it's just too much work to do it. And I think they felt it would be harder to then access information. So they haven't been able to implement that system. So you can still read unedited letters as a team, for example.
Thank you. And do you use a portable device?
We tried to use, we had a lot of laptops in the department. They didn't work. They don't work with it very well. We had a lot of iPads. They now sit in a cupboard gathering dust. Nobody can get them to work with Epic. It was tried lots and lots of times. It just didn't work. So, but in COVID, we all got issued with laptops. So most of us now use laptops, but it doesn't really work on anything smaller than a laptop. I think some people have managed to make it work, but no, we don't have smaller handheld devices. It's a proper laptop that's used for me personally, and whenever I see anyone else, it's a laptop. Okay.
And the question here is, can you share videos with patients?
Yes. In a virtual appointment, I have screen shared video fluoroscopy imaging and explain to the family exactly what I'm seeing. And sometimes I've been able to invite the community therapist to also join that appointment so that everyone gets the same information at once. So you can have multiple users join the appointment and you can share whatever you like over that appointment, as long as you're all in the secure portal and using the same link.
Okay.
You can also, I don't think you can upload video, but you can upload images into Epic. So there's a lot of wound assessment type images that get uploaded that I try not to look at, but I don't think yet you can put a video of a patient up into their file.
Okay. The other two, I think, are comments that we've agreed here in Northern Ireland that messaging in My Care when we get to that stage, so we will be able to message patients, and in South Eastern Trust, we have a better support system and preparatory work in place, I think, from learning from the other places that have gone live. I'll open up the floor if anyone wants to ask any more questions. If you want to unmute or raise your hand if you want to ask Eleanor anything else. We're all very shy. Lorraine?
Yeah, Eleanor, thanks for that. So we're going live in under 2 weeks in South Eastern Trust. I'm speech and language therapy as well, so it's nice to hear experience I can relate to. I suppose I'm thinking what you said about your iPads there. Certainly we have been doing some testing recently with iPads and Chromebooks as well. We also have Rover devices, which are iPhone 13s that our community staff are going to use, and certainly the feedback has actually been quite positive. I don't know whether things have moved since you had first tried them, but our testers seem to think that actually it's working quite well at the minute on iPads, and we've invested quite a lot in. Obviously, they're saying the best is your laptop, your PC, but it does seem that there are not as your primary device, but certainly there can be used. Is that your experience at all? You know, I know you were saying,
I think people could certainly read things on it. They could certainly access the information. I think it became more difficult. And at the stage when we all got issued laptops, everyone was home working. So you needed it to do Zoom, you needed it to do, you needed it to do a whole load of extra stuff. And then that's now just become the standard issue because I think it presented with fewer glitches. A lot of the iPads that were being used are 1, old, 2, it was the very old Epic. And the iPads were already in the trust being used for other jobs and then was sort of repurposed. So potentially, and then because we then all got issued with laptops, it might just be that we kind of shifted. And you're right, I haven't tried an iPad in a long time. That doesn't mean it wouldn't work. I just haven't tried it because my laptop does the job. And also I'm on site, so there aren't many times when I would need to, I don't sit in a car and go and see someone. I can maybe see that, if you're traveling around seeing patients, a giant laptop probably isn't what you want to be carrying around and seeing patients with.
And do you have Rover devices? Do you have the iPhones with the Rover app on them for your community staff?
And we don't have community here. We use the Rovers on the wards quite a lot, particularly for images. So if you want to take a photo and upload it to Epic, it works much better for that. So for some of our feeding plans where we want children sat in special seating or we want them given certain things in a certain order, that might come as a photo plan. And those photos would be taken on the Rover and kept in the Epic system rather than needing to be moved around a non-Epic system. So that's definitely something that we do use on site, but we don't have community. I don't think I know of a community trust using Epic yet. So I don't know. I think you might be first.
Yeah, I think we possibly are. Okay.
Yeah, thanks, Lorraine. There's another question in the chat about community. So I think if you have any questions, regarding community capabilities, laptops or anything like that, you're best to message your own Encompass staff in the trust, and they might be able to answer you and help you with that one. Anyone else? Any other further questions for Eleanor? I think we're good. That was really interesting, Eleanor, and thanks very much for your candid, open and honest report on it's not a disaster on go live day. It will all get worked through, and it's all worth it in the end. It sounds like. So
it's a brilliant system, and I'm not paid by Epic. Like, that's not like it has really changed the way we work in a very, very good way. And I would say, I think it is brilliant. And I've got colleagues that use the other type of Cerner, which is the other sort of competitor they're in other hospitals in London, and it's not nearly as good as ours. They're just, so.
Brilliant. Good to hear. Eleanor, thank you very much. That was fabulous. And just to let everybody else know, I know we will have people on the call here today, specifically interested potentially in in speech and language therapists, but our next edition of Digital Dispatches, which is actually next Friday, it's on the 3rd of November, and we have another EPIC staff experience from an occupational therapist. Originally a local girl, worked in different trusts across Northern Ireland, and then transferred across to the mainland. She again has used various systems and is now using EPIC for her occupational therapy. So join us for that one in next Friday. And thank you very much for everyone calling in today. And we'll hope to see you on the next one. And thanks again for giving up your time. Thanks very much, Eleanor.
You're most welcome. Bye, everyone.
Bye.